Now, what exactly does that mean? Now, you can see on the diagram at the bottom of the screen that we got on the left-hand side a healthy aortic blood vessel with the lumen in the center and the three walls, which is the tunica adventitia, tunica media, and the tunica intima. Now, what happens in the case of intramural hematoma or an IMH, that you get blood collecting in between the tunica intima and the tunica media layers, as you can see from the diagram on the right-hand side. Now, you can also see how it looks on a CT scan. Now, in a healthy individual, the borders are quite nicely well defined with no haziness. But in the case of an IMH, you can see that the walls are not as sharp. It's a bit hazy and it's not very clear. Now, obviously, aorta is a long blood vessel. You can get an IMH at different parts of this long blood vessel. So we need a classification system to identify what type of pathology we are dealing with. So for this reason, we use the Stanford and the DeBakey's classification system. And yes, this is the same system that we use to classify aortic dissections as well. So how do we use this? How do we classify an IMH? Now, according to the Stanford classification system, if it involves the ascending aorta, we call that a type A IMH. If it doesn't involve the ascending aorta, and if it is distal to the left subclavian artery, as you can see on the right-hand side, we call that a type B IMH. Now, that's the Stanford classification system. We can also use the DeBakey's system as well, which is divided into type 1, type 2, and type 3. So interestingly, our patient had an IMH, but on top of that, she also had what we refer to as an aberrant subclavian artery. So what exactly is an aberrant subclavian artery? Now, it's not very common. It's found in 0.4 to 1.8% of the population. So what an ARSA is when you get the right subclavian artery branching off from the aortic arch directly. Now, what that means is in a healthy, normal individual, well, in most individuals, we get the right subclavian artery branching from the brachiocephalic trunk. Now, to illustrate that purpose, the point, I've got a little 3D sketch on the screen. I hope you can see my screen. So what you can see here is you can see the heart. And on the left-hand side, what we get is we get the left subclavian artery branching directly from the aortic arch and going into our arm. And on the top, we got the common carotid artery, which is going up towards our neck to supply our head. On the right-hand side, it is forming the brachiocephalic trunk. Now, and then the brachiocephalic trunk branches off to form the right subclavian artery and the right common carotid artery that goes towards our neck. Now, what happens in a patient with an aberrant subclavian artery is that instead of the right subclavian artery branching off from the brachiocephalic trunk, it branches directly off from the aortic arch. So that's what the variation is. It's not harmful, but sometimes when it is combined with an IMH, it can cause problems, as we would see shortly. Now, we can also see a reconstructed image. This is from a real patient, not our patient. It's a different patient. That you can get the contrast in the aortic arch. On the left-hand side, the subclavian artery branches directly from the arch, but on the right side, instead of branching from the brachiocephalic trunk, it branches directly from the aortic arch. Now, let's move on to the case presentation. So our patient was a 73-year-old lady who presented to the emergency department a couple of years ago with severe epigastric pain that was radiating towards her back. Now, it was also associated with breathing problems, and it was right-sided, and it was pleuritic in nature. Now, she didn't have a great deal of a past medical history. She had high blood pressure, she had high cholesterol, and she had a right total hip replacement. Medications, again, she wasn't on a great deal of meds. She was taking simvastatin, bisoprolol, and she didn't have any drug allergies. Social history was quite unremarkable. She was independent. She was living with her husband. Following the right hip replacement, she was mobilizing with a stick. She was a non-smoker and she drank moderately. Observations weren't that exciting. She had the high respiratory rate of 22 and the high heart rate of 100 beats per minute. So she was slightly on the tachycardic side. On examination, she was quite pleasant. She was oriented, she was alert. She had a GCS of 15 out of 15, and she had an unremarkable respiratory and cardiovascular examination. So as we know, when we get a patient who is short of breath, who has chest pain, is tachycardic, one of the things that we suspect is a pulmonary embolism. And also with chest pain that radiates towards the back, aortic dissection is also another reasonable suspicion to have. So what we did is we did a CT pulmonary angiogram to rule out the possibility of an aortic dissection as well as a PE. We did an ECG also, which showed sinus rhythm, which was sinus tachycardia with a rate of 100 beats per minute with no ischemic changes. The CTPA didn't show a dissection, but it showed the type B aortic intramural hematoma on the background of the aberrant right subclavian artery. So got some images from our patient, so you can see what was going on. On the left-hand side of the screen, you can see a sagittal section of the patient's pathology. You can see the hematoma in this region, and here you can see the cross-sectional view. To orientate yourself, this is the vertebra. This is the back of the patient. This is the front of the patient. You can see the ascending aorta with contrast inside, and you can see the pulmonary trunk. You can see the descending aorta at this point, and the IMH initially on presentation measured 7.73 millimeters in length. So this is the descending aorta. You can see the hematoma, which is this gray-colored collection or area. Now, one of the interesting things that you can see from the first pictures, you can see these tiny things coming off from the aorta. Now, you might be thinking, what are these things? Now, these look like tiny blobs and blobs that is coming off from the descending part of this patient's aorta. Now, these are not normal, okay? So we don't, a normal healthy individual, we don't get these things. These are what we refer to as ulcer-like projections, which we will be going over next. Now, ulcer-like projections are sometimes seen on the contrast-enhanced CT in patients with a recent aortic intramural hematoma. Now, what they represent is, you can think of these things as in diverticular disease, when you get outpouching of the intestinal wall, it's a bit similar to that. You get outpouching of the aortic wall. Now, these things are not very common, but in the case of a patient with the IMH, about 40% of these patients will have ULBs. The bad news is that if you have ULBs and you have an IMH, the prognosis is not very great for the patient. Now, when do we get these things? So it either develops at the same time as the IMH, or if it develops later, it develops in the first month from the presentation. So now this is a reconstructed image that shows the ULPs a bit more clearly. So you can see these things, which almost looks like tiny mushrooms coming off from the descending aorta. And here again the right subclavian is a bit more clear. The labeling is wrong here, so I do beg your pardon for that. So we made a mistake. This should say the right subclavian artery. Sorry. I mean on the left-hand side. And then if I move on to the next slide, here we talk about the management of our patient. So when the patient presented to us, we saw the scan, we knew what was going on. So we discussed this patient among the vascular, interventional radiology, and the cardiothoracic team. And a decision was made to treat the patient conservatively with strict blood pressure control. So what we mean is we didn't decide, we thought surgery isn't for this patient, given the fact that it's a type B IMH. So the patient was started on a labetalol infusion at a rate of 20 milligrams per hour. The systolic blood pressure was titrated to be strictly between 100 and 120 millimeters mercury, with close monitoring in the progressive care unit for 72 hours. Now, exciting news, we repeated the CT scan 4 weeks later, and what did we see? So we saw the hematoma was actually getting better. Now, this is the cross-sectional view. If you remember from the initial presentation, it was 7.73 millimeters in length, but 4 weeks later, quite lucky for the patient, it came down and it was 3.04 millimeters. So it's healing, it's getting better, okay? And you can also see an MRI a year later, which shows almost complete healing of the hematoma. Now, it's not very common for the hematomas to heal completely and for the aorta to go back to almost normal to how it was. So that's why this case presentation was a bit unique compared to other cases we have seen in the literature. And then fast forward for some more images. What you can see here is, if you remember, we talked about ULPs. This is the first scan of the patient showing, you can see 3 ulcer-like projections here. But fast forward a few weeks, few months, these ULPs have disappeared and they have healed itself as well, which was quite nice and quite interesting. And the patient went on to do really well following the blood pressure management. So how do we manage type B IMH in general? Now, beta blockers are the mainstay of treatment. The reason being it controls both the heart rate as well as the patient's blood pressure. Now, other medications such as calcium channel blockers may also be used if beta blocker control is not sufficient. Another agent that we can use for these patients are ACE inhibitors. Now, these have two advantages. Number one, it helps in the control of blood pressure. And number two, it helps in remodeling the aorta. Now, after an IMH, the aorta is not quite normal. So with the help of ACE inhibitors, it can help it to achieve some sort of normality compared to how it was before. Another important part of the management is close monitoring with CT scan. This is extremely important because sometimes what can happen is that the IMH can get worse. You might get impending signs of rupture. So you need to keep a close eye on these patients. Any patient who is not responding to blood pressure control, despite being on multiple agents, or if the pain is not controlled, or the IMH thickness is worsening, these patients would be considered for a TIVA. Now, TIVA is a transendovascular repair of the pathology. So what we do is we go inside through a blood vessel without opening the patient's chest. It's a minimally invasive procedure, which we go inside through a blood vessel and we repair the aorta using a very, very minimal approach. Now, some cases, things doesn't work out. Patients with a complicated type B IMH, remember the keyword is complicated, okay? Our patient wasn't complicated, she was quite straightforward. In cases of complicated type B IMH, like we discussed, these patients would need endovascular repair with a TIVA. Some of the common reasons why it might be complicated include aortic rupture, impending aortic rupture, or concerns about clinical deterioration. So we talked about type B IMH repair. I thought it might be a bit interesting to look at type A IMH as well, which we repair with surgery. And I got a video here which clearly demonstrates how the IMH looks inside the patient, inside the aortic wall. Keep in mind, this is not our patient. It's a different patient from a different hospital to illustrate the point of how type A IMH is repaired. So what we do is, this is an operation where we open the breastbone of the patient or the sternum. Okay, so what you can see in this picture is you can see the sternum has been opened right at the center. Okay, so this is the head end of the patient at the top. At the bottom, you have the bottom end. On the right, you have the patient's left, and this is the patient's right. We open the sternum, and then we use retractors to spread the sternum apart. And then what we do is we can see the heart quite nicely. You get some pericardial fat. So the heart is almost lying underneath here. But what you can see here is you can see the aortic arch coming off from the heart. In this corner, we can see the right atrium where my mouse pointer is. Now, what happens is in these operations, we have to stop the heart. So what we do is we take the job of the heart outside of the body using a heart-lung machine. Now, another important part is we can't carry out the operation when the heart is beating, so we need to stop the heart to allow us to provide a bloodless field where we can do the operation quite easily. So what we do is we use an agent called cardioplegia, which contains potassium chloride. And the idea of the cardioplegia solution is to induce intentional cardiac arrest. So when the heart gets this solution, what happens is the heart stops beating. Okay, it's a cardiac arrest, but it's controlled because we can revert the heart back to how it was previously. Now you can see at the moment the heart is beating, and eventually it will stop beating. It's slowing down now, slowing down. And once it stops beating, what we do is we make a cut in the aortic arch to expose the hematoma. So what we do is we take the scalpel, we make a little incision in the aortic arch, and hopefully you should be able to see the hematoma lying inside the vessel wall. Now, this thick and dark red area is the hematoma. As you can see, as we defined IMH earlier, it's not active blood flow, it's blood clot, which is not mobile, it just stays in the same place. So what we do is we take a pair of forceps or grabbers and we take off the hematoma from this vessel wall. Okay, because we don't want clotted blood lying in the aortic wall and causing all sorts of problems. So for the sake of the time, I'm going to fast forward this video. So what we do is we evacuate the hematoma as much as possible. And following that, we take off the diseased section of the aorta and we repair that with the aortic mesh. Okay, so if I fast forward here, you can see the heart is beating nicely again. So the effects of the cardioplegia solution has been taken off or has worn off. And you can see this white colored thing is the aortic mesh. It has little ricks, which gives enough space for it to expand when the blood pressure and when the heart rate increases. So he's a happy patient now. The pathology has been fixed. So what we do now is we close the sternum with metallic wires, and the patient hopefully goes home in the space of a few days. Okay, I'm going to go to the next slide in the interest of the time. So what are the learning points and conclusions from this presentation? So it illustrates the importance of strict blood pressure control and follow-up scanning in patients presenting with type B IMH. It is also very important to monitor these patients regularly. And if blood pressure control alone is not sufficient, further intervention such as TIVA, and in some cases, surgery might be needed. Now, we are speaking about type B IMH on this slide. So therefore, even though complete resolution might be achieved, as in our case, these patients need to be kept under constant surveillance to make sure that IMH is not progressing any further, or that there are no further signs of any other IMH coming back. MRI remains the gold standard imaging modality in the follow-up phase. And the reason for that is that small IMHs might be missed on CT scan and could be picked up by MRI. During the early course of IMH formation, the hematoma shows an iso-intensity signal on T1 imaging and a hyper-intensity signal on T2. Now, one of the reasons is that after the first couple of days, the oxyhemoglobin gets converted to methemoglobin, okay, which causes a hyper-intensity signal in both T1 and T2 modalities. Now, what that means is this makes MRI an excellent choice to help assess the age of the IMH. So that concludes my presentation. Thank you very much for listening to my talk this morning. If you have any questions, I'm more than happy to take them now. If not, I will move on to them.